So the concept that I'll discuss is about coronary artery disease and other related heart diseases. Before we discuss this disease process, is that you have to be familiar with the different coronary arteries that we have in our body. So as you can see in this image, we have here the right coronary artery. We have the left main coronary artery. And that left main coronary artery bifurcates right here. So we have here left circumflex, which goes around the heart. And we also have here LAD, or left anterior descending coronary artery. So we have here RCA. We have the left main coronary artery. And it bifurcates to left circumflex and left anterior descending coronary artery. So these different coronary arteries supplies the different parts of the heart, and it's very important that these coronary arteries are not blocked, or it's very important that there's no blockage around it, because it will cause ischemia in the heart. And again, it really depends on where is the ischemia, where is the blockage, and we will discuss that in the diagnostic test later on. So with coronary artery disease is a type of blood vessel disorder that is included in the general category of atherosclerosis. And you've learned this terminology, the atherosclerosis, way back when you take your pathophysiology. Now, atherosclerosis is often referred to as hardening of the arteries. And as you can see in this image right here, is that this blood vessel right here, when you look at this part right here, these are the lipid deposits. Okay, and there are many factors why your patient has this lipid or fatty deposits. And we have different risk factors. It could be modifiable or non-modifiable. And let's start with the non-modifiable risk factors. So the non-modifiable risk factors, number one would be increasing age. So as we age, it also predisposes us to have coronary artery disease. Second one would be the gender. So this is more common in men than in women. And also, based on research, by ethnicity, it's more common in white men than in African American. Genetic predisposition also has a big role for a client to be at risk to have CAD, and also familial history. So we have to make sure we assess that as we admit a patient, and we'll look at what are the risk factors that your patient has in relation to the disease process. Now, the modifiable risk factors, when you say modifiable, it means something we can change, something we can manage, would be the hyperlipidemia. So again, these are non-modifiable. So before I move on, non-modifiable. And now let's discuss the modifiable. So the modifiable risk factors are hyperlipidemia. That's why in the diagnostic procedure, we have to check the total cholesterol of the patient, triglycerides, LDL, HDL. Another one would be high blood pressure, diabetes, smoking, physical inactivity. So if your patient doesn't exercise or has a sedentary lifestyle, is also one of the risk factors. Obesity. So if your patient is obese, that also predisposes them. Other contributing risk factors are fasting blood glucose, and fasting blood glucose is also one of the diagnostic tests that we do for diabetes mellitus. Psychosocial risk factors also, like if your patient has depression, any history of hostility, or if a client is always under stress that also predispose them, or any patient who has elevated homocysteine. And elevation at homocysteine, when you look at a lab result of your patient and you saw that, means that there's a possibility that your patient has thrombus or clots that you have to investigate further. Now with CAD, when you look very closely on the blood vessel, and remember, this doesn't happen in one day. It takes time. So let's say that your patient has narrowing of, let's say, RCA. So let's say this is the blood vessel, and let's say this is a part of RCA, let's say. And let's say this part has narrowing. These are the lipid deposits. So when you look at it, it means that if there's lipid deposits there, the blood will not be able to pass through completely. And what's going to happen in this area right here, there will be an increased pressure. That's why patients who have CAD, they have also hypertension. But again, this happens over time. There will be increased blood pressure. Later on, this will cause ischemia. And if this is an RCA, it means ischemia on the right side of the heart. And what's gonna happen again if this is left untreated? This patient will have later on a complete blockage. So if your patient doesn't go to the physician or nurse practitioner to be checked out of what's going on, there will be a complete blockage, and this will lead into necrosis. Okay, and you've learned in pathophysiology, if there is any ischemia, your patient will present with chest pain, or also known as angina pectoris. And remember that chest pain doesn't mean that your patient has an MI right away, because we have to rule out if this chest pain is pulmonary related or cardiovascular related. That's why we do 12-lead EKG and other diagnostic tests. So with chest pain, or also known as angina, there are different types of angina, and you know this already, but let's just put it here. We have here Prince-Metal angina, and Prince-Metal angina is also known as variant angina. And this type of chest pain occurs even the patient is at rest. The second type of angina is microvascular angina, which is very commonly seen to postmenopausal women. The third type of angina is chronic stable angina. So by just looking at the terminology, it's chronic, it's stable, so we don't have to panic. But remember, this patient will have a lot of maintenance when it comes to managing that angina, because of course we don't want angina to that patient. And chronic stable angina is triggered by an activity, so whatever activity that is. Now let's go back in here, and I mentioned that if your patient is left untreated and there will be a complete blockage that can lead into later on necrosis, this patient will have acute coronary syndrome, okay, or also known as ACS. And ACS can be MI, myocardial infarction, or it can be an unstable angina. And we will discuss it in a separate video discussion. So as you can see here, is that CAD can lead into different disease processes. As I've mentioned, it can lead into hypertension later on. It can lead into ACS, worst case scenario. And if the heart gives up, patient can have heart failure. If high blood pressure is out of control, your patient will have hypertensive crisis. Okay, so in short, we really need to do something on the prevention side so that this will not happen. Or if your patient already has it, then we need to know what would be best for this patient, what specific medications would help them, so that we can manage it properly and that we can prevent further complications. So for the clinical manifestation, I already mentioned the chest pain, okay, and changes in the blood pressure. What else? You will also see some changes in their vital signs. But then again, it really varies per patient depending on the progression of the disease processes. Now, the different diagnostic studies that are done for this client would be, of course, if they have chest pain and we want to rule out if this cardiac or pulmonary related, one of the diagnostic tests to be done would be 12-lead EKG. And as a nurse, you really need to know how to interpret 12-lead EKG at least, so that you can identify, let's say if this is cardiovascular related, you want to know if this is a real MI, what lead is affected. Is it lead 2, 3 AVF, that is right ventricular infarct? Other than that, the other is left ventricular infarct. So the management with those type of MIs would be different. And remember that, and we will discuss that in a separate video discussion. Now, 12-lead EKG is one of them. Now, with the others, as you can see here, the healthcare provider might also recommend stress echocardiogram. So, with stress echocardiogram, what they will do is that your patient will have an IV, and then this procedure actually takes 4 to 6 hours, and your patient needs to be NPO at least 8 hours before the procedure. Your patient cannot take any caffeine. Okay, cannot take any caffeine before the procedure because that can lead to inaccurate result. Another thing would be your patient needs an IV in this procedure. Your patient will walk in a treadmill. So that's why it's stress echo, because stress echo will try to assess on how the heart responds if there is an activity or if there's any arrhythmia that we need to further investigate. So the physician does this. Okay. Now, as you can see on the left side right here is your patient is also undergoing echo, but this is more on ultrasound. And then again, this is non-invasive, so it just looks at the parts of the heart that has any ischemia, or it also looks at the ejection fraction of the heart, because we want to know the ejection fraction of the heart, and the normal is more than 55%. So as you can see here, there is no specific nursing consideration compared to stress echo that your patient needs to be NPO before the procedure and no caffeine before the procedure. Now, with echocardiogram, there's another type of echocardiogram, and that's the name is TEE, transesophageal echocardiogram. And with TEE, since it's transesophageal, the approach is starting from the mouth down to the esophagus right here. This is an invasive procedure. You need to make sure there is consent, that the patient knows the complications of this procedure. And the thing with the, again, it looks at the or it quantifies the ischemia, or if there's any infarction going on. It also looks at, the ejection fraction of the heart. Okay, and after TEE, you want to make sure that you check the gag and swallowing reflex of the patient. You also need to monitor the vital signs before and even after the procedure. And of course, you assess the level of consciousness of the patient. Now, another type of diagnostic test right here would be PET scan. So this is PET scan, positron emission tomography. So with PET scan, it's used to identify and quantify ischemia and infarction in the heart. So as you can see, there are different images here that the healthcare provider needs to interpret of what's going on in the heart. So that's another type of diagnostic test. Another thing is that they will do an angiogram, coronary angiogram. So as you can see, the approach of the coronary angiogram is it will start from the femoral area. They will use a catheter, and from there it will go to the heart. Okay, so as you can see there, this is the catheter coming from the left femoral artery going up to the aorta, and it's sitting on the aortic valve. So again, coronary angiogram, remember, any diagnostic test that has a gram right here, it means that they will use a contrast. So remember that with coronary angiogram, since it has a contrast, before the procedure, you want to make sure that you check the BUN and creatinine of the patients, especially creatinine, because creatinine quantifies the kidney function. And remember, you've learned from fluids and electrolytes, BUN can be elevated not only because of kidney failure but also metabolic disorder. So we cannot really use BUN or BUN to quantify the kidney function. What we want to use is the creatinine. So you really have to look at that. So this is before the procedure. You also want to make sure if your patient's diabetic and taking of metformin, you have to hold metformin at least 48 hours before the procedure, because again, metformin, if your patient has kidney or renal insufficiency, that also predisposes your patient to have renal failure later on. And again, since this procedure is using contrast, that can also exacerbate the renal insufficiency. So you don't want that. So you want to make sure that you want to hold metformin 48 hours before the procedure. 3, you want to check for any allergies, because again, we're using contrast here. Now this is pre-procedure. Now after the procedure, so post-procedure, you want to make sure that you hydrate the patient. Okay, hydrate the patient, check INO. Okay, and of course, routinely you want to check vital signs, LOC. You either do your focus assessment, cardiac assessment, or you want to do head-to-toe assessment after the procedure. So you want to make sure you always have baseline before and after the procedure. So as you can see with coronary angiogram, on this side, you can see what they look at. So from here, you can see if there's any blockages in the coronary artery. Okay, so that's one of the diagnostic tests. And of course, in addition to all of this, I think I mentioned already the serum lipids, right? We also need to check our baseline. So if you want to do CBC or CMP, MAG and FOS, you want to check that. You want to check also the lipid panel. Okay. So this is purely for CAD. And of course, if your patient has possible MI, then there will be more diagnostic tests that we can add for the blood tests. So now, how do we manage CAD? So once your patient's diagnosed to have CAD, then of course your patient will need specific medications to manage CAD. And of course, we just talked about earlier hyperlipidemia. Then we have to give something for that. So for the meds, your patient will have lipid lowering agents. So for sure you're already familiar with statins. So statin drugs are the most widely used lipid lowering agents. Okay, and you've learned in pharm that with statins you have to give it at night. Because why at night? Because at night it's when the cholesterol is synthesized in the liver. So you want to block that synthesis. That's why you want to give it at night. So statins is also known as HMG-CoA reductase inhibitor. Okay, because HMG-CoA reductase is an enzyme that promotes cholesterol synthesis. So you want to inhibit that. So the most commonly used statin is or are lovastatin, pravastatin, simvastatin, fluvastatin, atorvastatin, rosuvastatin. Okay, another medication that we can give to our patient is niacin. And niacin is a water-soluble B vitamin, and it interferes the synthesis of, it inhibits LDL and triglycerides. So you want to give this also. Another medication would be fibric acid derivatives. So the most commonly used is gemfibrocil. And gemfibrocil are effective in lowering very low density lipoprotein, or the VLDL. And of course, triglycerides. And the good thing about this medication is that it also increases HDL. And we want the HDL to be high. Now, another type of medications would be the bile acid sequestrants. And the bile acids, the most commonly used is cholestyramine. And remember from pharm that cholestyramine is actually a drug of choice for pregnant women. It is the most safest bile acid sequestrant you can use for them. Another medication that we use would be ezetimibe. That is also a bile acid sequestrant. Now, remember, these medications will lower the lipid levels. Now, the other medication that we give to our patient is or are the antiplatelets. Why antiplatelets? Because going back to the pathophysiology earlier, your patient will have a lot of lipid deposits, and there's a possibility that your patient will form thrombus, and that thrombus can later on lead into emboli, and we don't want that. So you want to give antiplatelets. So low dose of aspirin will help. So aspirin 81 milligrams PO daily. But the thing with aspirin, it can cause a lot of GI irritation, and you really have to watch for that. So if your patient is complaining of that or any heartburn, then we can suggest that this patient can take ranitidine to help out. But then again, you already know that ranitidine has a recall this year. So we want to be careful on that because it has a cancer forming chemical. But then again, evidence-based practice, you can combine aspirin with ranitidine just to decrease the heartburn. Now, for high-risk women, okay, so I just want to put here GI bleeding for aspirin that you have to watch for. Now, for high-risk women who are aspirin intolerant or who cannot tolerate aspirin, then we can recommend clopidogrel or also known as Plavix. But of course, for NCLEX, you want to make sure you know the generic name because you will be tested on that. Okay, so clopidogrel. So now we're done with the medical management. Now let's discuss the nursing management. So our nursing management will be more on identifying the person at risk for CAD, and we already talked about the other risk factors earlier. So you want to look at those risk factors. You assess the eating habits of the patient, the lifestyle. So if they're smoking, if they're drinking alcohol, or if they have any negative psychologic states, you really have to discuss that with the patient, or if you can have consult to help you out on that. Now, in educating your patient, you want to consider also the attitude and beliefs of your patient about health and illness. And your health teaching will be focusing more on the diet and also lifestyle modification. So as you can see here, this is based on American Heart Association, the heart healthy diet, or the 2-gram sodium diet of your patient. So you want to make sure that you emphasize to your patient that there should be a variety of fruits and vegetables, whole grains, low-fat dairy products, skinless poultry and fish, nuts and legumes, and non-tropical vegetable oils. So that's it for CAD, and we'll discuss more on the hypertensive crisis, and the other heart-related disorders in other video discussion. So if you have any question, let me know.